Thank you, sir, for such a wonderful presentation. Our third speaker for this session is Professor Adrian Hill. He is a consultant physician and endocrinologist at Salford Royal Hospital in the north of England, and he holds a chair at the University of Manchester. He also holds the post of visiting fellow at St. Peter's College, Oxford. He will talk on erectile dysfunction. Is it curable? He's not here physically. He will join us online.
So thank you very much for inviting me to speak today on the topic erectile dysfunction, is it curable? This is where I work at Salford Royal Hospital in the northwest of England, where I am a consultant in endocrinology, and I'm also a professor of medicine at the University of Manchester. If you want to contact me, here's my email address. It's adrian.heald@srft.nhs.uk. So what we want to talk about today is a number of areas around the subject of erectile dysfunction. I'm going to cover hypogonadism in men. I'm going to touch on the European male aging study, on screening hypogonadism, on erectile dysfunction and its relation to cardiovascular risk in men, and finally on treatment options. In reality, when we are considering erectile dysfunction, patients, in other words, men, often don't want to talk about it, and we as doctors don't want to ask because it could make the consultation about twice as long. So it's often not something that we talk about, but it's terribly important in anybody who has diabetes or has an underlying cardiovascular risk profile. We do ask about this, and really in any older male patient. Not to forget the pituitary gland. The pituitary hormones are just coming up here. And of these, LH and FSH are the hormones that control the gonadal function in both men and in women, or principally control gonadal function. The hormones from the anterior pituitary are under control from releasing factors that come down the pituitary stalk from the hypothalamus. These generally are releasing factors for the hormones, with the exception of prolactin, which is under inhibitory control from dopamine that comes down the pituitary stalk. So just to remind you a little bit about the physiology. Hypogonadism is an issue for many older men. It can present with impotence, so erectile dysfunction or libido problems. It can present as non-specific symptoms such as tiredness and lethargy. It can present as irritability or loss of verve, which means loss of enthusiasm. And there was a lot of debate for many years about whether the andropause in men, in other words, an equivalent of the the female menopause, in other words, the male menopause, was actually quite a common phenomenon. So until 2010, when this paper was published, which was led by Fred Wu, Professor of Endocrinology in Manchester, based on data from the European male aging study, it was thought that actually the male menopause might be quite common. But using a syndromal diagnosis based on poor morning erections, low sexual desire, erectile dysfunction, combined with a low circulating serum testosterone level, it actually turned out that within this group of older men, 3,369 older men recruited in Europe, that actually the inverted commas male menopause, close inverted commas, were not actually that common. So it kind of changed the thinking about it, but there's no doubt that erectile dysfunction is a phenomenon that we need to think about every day in our work as endocrinologists and diabetologists and primary care physicians involved in those areas. And also important that we do ask our patients about this, particularly if they're an older, middle-aged or older man. In terms of how we assess this, it's really important just to think about the basics here, that we don't just want to measure serum total testosterone. It's important to be able to adjust the serum testosterone or sex hormone binding globulin, and also to measure LH and FSH, and ideally measure albumin as well. But in order to estimate circulating free testosterone, using the calculator shown here, which is available at the website, the ISSAM website, we can estimate the free testosterone if we have sex hormone binding globulin and ideally the albumin as well. And that will give us additional information, particularly when the total testosterone level is borderline, in other words, where it's in nanomoles per liter, somewhere between 7 and 11 nanomoles per liter. So this algorithm that's based within the website enables us to estimate the circulating free testosterone. And generally, we would say that a circulating free testosterone of less than 225 picomoles per liter is diagnostic of hypogonadism. There's a kind of borderline range between 190 and 225, and some people would take the lower threshold of 190, but anywhere definitely less than 190, between 190 and 225, probably borderline. More than 225 picomoles per liter is likely to be eugonadal, even in a man who's complaining of erectile dysfunction. There are very nice ways of kind of interpreting the data if we also have LH and FSH. If we have a picture of a low testosterone, low LH, and low FSH, that's compatible with a pituitary or hypothalamic cause for the gonadal failure. If it's a primary hypogonadism picture, we generally see a low testosterone and then reasonably high LH and FSH. The commonest thing that I see and that many of you will see is when hypogonadism is associated with central obesity. That gives us a picture more like bullet 1, but with probably a higher testosterone level, and that's related to obesity and its effects on the hypothalamus and essentially an inadequate secretion of LH and FSH from the hypothalamus in relation to being able to ensure that the gonadal testosterone production is sufficient. So we might see a testosterone level of 6 or 7, and then LH and FSH levels in single figures, and that's a central obesity effect affecting the hypothalamus, which then results in this picture of hypothalamic hypogonadism in men who are centrally obese, often the metabolic syndrome. We have some very helpful guidance from the NICE body, the National Institute for Health and Care Excellence, which is freely available. You can access it from Pakistan and from other countries in South Asia. This was only revised in June 2024 and gives very clear help in terms of how we approach the diagnosis and management of erectile dysfunction in men. And here's just another screenshot around the importance of considering psychosexual factors as well as organic factors in the etiology of the erectile dysfunction. Just recently, Mark Livingston, who's based in Wolverhampton in the UK, and I published a perspective on the diagnosis and management of hypogonadism, which is freely available online in the Journal of Diagnostics. We highlighted a number of features that need to be considered when we are approaching the workup, in other words, the investigation of a man presenting with potential hypogonadism, and particularly in this case with erectile dysfunction. So things we need to consider: the physiology of testosterone. Testosterone levels are higher in the morning than they are for the rest of the day, so we need to check levels in the morning, anytime after 7 a.m. Testosterone levels are lower in the evening. There's been quite a literature on seasonal variation in levels, but we actually have recently published, and we're presenting it at the Belfast Endocrinology meeting on Monday next week, the finding that certainly at the latitude that we are in England, which is more northerly than the latitude in Pakistan, the difference between testosterone levels across the year between seasons is minimal. So it's not something that we need to consider in our interpretation of testosterone levels. Things that we do need to consider are acute illnesses and infections that can lower testosterone level, obviously chronic conditions such as diabetes, liver disease, and kidney disease, lower testosterone level, as can inadequate sleep or disrupted sleep cause a lower testosterone level. Physical activity, in particular regular exercise, can result in an increase in testosterone levels. Certain medications such as corticosteroids and opioids may interfere with testosterone secretion and result in lower levels. We also need to consider the potential certainly in Europe. I realise that wouldn't be a huge issue in Pakistan for alcohol abuse, but also need to consider drug abuse as well as factors that can lower the level of circulating testosterone. As I've said, when we're interpreting the total testosterone, it's important to consider the sex hormone binding globulin and ideally adjust for that using the International Society of the Aging Male calculator to estimate the circulating free testosterone level. So these are factors that we need to consider in terms when we are going through the diagnostic process. Does the person have actual hypogonadism? Now, moving on to erectile dysfunction itself, there was a very great cardiologist who pictured here, who sadly died some years ago. And Graham made the point in all of his lectures and in many of his papers that there isn't a close connection between erectile dysfunction and cardiovascular disease. And although you might think this is a bit rude, but he was making the point with this quote, "The way to a man's heart is through his penis," is that if men are presenting with erectile problems, we need to consider that they may not just have hypogonadism, they may have hypogonadism, but separate from that, they may have cardiovascular disease, particularly coronary artery disease, because what happens is that the blood vessels in the genital area are often the first ones to be affected by the atherogenic process because they're only small vessels in terms of the blockage of those vessels and the associated symptoms, which in this case are erectile dysfunction. So take-home message is that if we have a man who's presenting with symptoms of erectile dysfunction, we need to screen for hypogonadism, but also screen for underlying cardiovascular risk factors. In other words, make sure that you check their blood pressure, that you've screened for diabetes, and you've done a check of their random fasting lipids. So in tribute to Graham, the cardiologist, we always need to make sure that when someone presents with erectile dysfunction, we also screen for cardiovascular risk as well and target those parameters if they are showing hypertension or dyslipidemia or even pre-diabetes, but certainly diabetes itself. And in that area, with colleagues, just around 9 years ago, we published a paper where we describe the way that PDE5 inhibitors, in other words, the agents used to treat erectile dysfunction, actually in an observational epidemiological study was shown to associate in diabetes men with a lower mortality rate. And I'll just show you the forest plot here. So this was the multiple regression analysis. And you can see right at the bottom, PDE5 use and of course statin use were associated with a lower risk of death in men with diabetes. And this was in spite of adjustment for smoking, for hypertension, previous myocardial infarction, previous stroke, and importantly for HbA1c and social disadvantage. So independent of all of these factors, use of a PDE5 inhibitor, and in many cases just on an occasional PRN basis, was associated with a decreased risk of death in men with type 2 diabetes. And if we looked at men who'd had a prior myocardial infarction and had type 2 diabetes, most of them were type 2, a few of them were type 1, but if they'd had a prior myocardial infarction and had diabetes, then if they were prescribed a PDE5 inhibitor, which is the dashed line, the Kaplan-Meier curve clearly showed a lower mortality rate than men who were not prescribed a PDE5 inhibitor, which is the solid line. So take-home message from this and from other studies that have been published subsequently is that the prescription of a PDE5 inhibitor in men with diabetes, and in particular in men with diabetes and a history of coronary artery disease event in the form of myocardial infarction, was associated with a lower death rate. So important in that it highlights the link between erectile dysfunction and cardiovascular risk, but also demonstrates there's something we can do about it, that the PDE5 inhibitor will not just help the erectile function, but also has the potential to save lives. and thinking about the mechanisms of this and the mechanisms around the endothelial dysfunction and the relation of endothelial dysfunction both to diabetes and also to hypertension and hyperlipidemia. In both these situations, both diabetes and hyperlipidemia, stroke hypertension, there is oxidative damage to the endothelium of the blood vessels. There is decreased production of nitrous oxide and there's increased consumption of nitrous oxide. What the PDE5 inhibitors and also testosterone do, if it's appropriate to give testosterone as well, is to reverse to some degree that process to ensure that the vessels are relaxed in terms of smooth vessel relaxation and also have positive effects in terms of growth factors within the endothelium that will promote a healthy vascular endothelium. So that process of oxidative damage and changes in nitrous oxide handling in the endothelium, or at least partially reversed by the PDE5 inhibitors, and also there are positive effects on the cellular matrix within the endothelium, on the balance of growth factors within the endothelium, and also on smooth muscle relaxation. So there's a clear physiology and pharmacology underlying the beneficial effects of PDE5 inhibitors in this situation. Just finally, to mention a non-endocrine approach, there has been a building evidence around the use of corporeal therapy. In other words, the use of ultrasound technique to low intensity extracorporeal shockwave therapy, which is a kind of ultrasound technique to improve erectile function. This paper was looking at men with Peyronie's disease, but also there's an evidence base in men who have erectile dysfunction proved resistant to treatment with PDE5 inhibitors and testosterone. And in this meta-analysis, the extra corporeal shockwave therapy was shown to have the potential to decrease the plaque size within the arteries in the penis, to improve the erectile function. And this and other evidence has been used to, should we say, support the application of this technique, not just in men with Peyronie's disease, but also in men with erectile function not responding to pharmacotherapy. This obviously wouldn't be done in an endocrinology clinic setting or diabetes clinic setting, but would need referral on to a urologist. So going forward from here, I think there will be, certainly within our healthcare system in the UK, increasing investment in the treatments for erectile dysfunction, and also an increasing awareness of the importance of screening for cardiovascular disease. So my take-home messages are, number one, if you're working in primary care, please do ask your patients if they are middle-aged to older men, if they are already with diabetes, with hypertension, dyslipidemia, or with cardiovascular disease, if they're having problems with erectile dysfunction, because that may be a warning of underlying significant vascular problems. Please don't forget to check the blood pressure, to check the lipid profile, to screen for diabetes, ideally with an HbA1c, but also to screen for hypogonadism and to treat accordingly. And I've given you some guidance there. Don't just check the testosterone, check the sex-hormone binding globulin, the SHBG, the LH, and the FSH. PDE5 inhibitors, in other words, particularly sildenafil and tadalafil, and of course, tadalafil can be given as a daily dose of 5 milligrams, are not only good for erectile function, but can reduce cardiovascular event rate in people who are at risk and also reduce mortality rate. But if pharmacotherapy doesn't work, please do refer on to urology. There may be pharmacotherapies that wouldn't normally be available to us, such as alprostadil. They may also be considered for other treatments, such as the extracorporeal shock therapy, which can be of benefit if there's evidence of, should we say, other pathology at work in the penis. So to answer the question, is erectile dysfunction curable? It's not exactly curable, certainly is treatable. Thank you very much for listening to my talk, and I hope you have a very good day.
I thank you all of our speakers for their wonderful talks. Unfortunately, because of the shortage of time, we are not taking any questions for this session. We'll only take comments from our chairpersons.
Quinton, thank you for such a elaborative discussion on how to manage hypogonadotrophic hypogonadism. It's very difficult topic. It's not easy to manage. Early initiation of gonadotrophins, especially SCG and recombinant FSH, and then monitoring of testosterone level along with serum FSH, and then dose titration is what is required, and very nicely summed up. The point is, it's not we won't be able to get results in a few weeks to few months time. Sometime it may take few years. So be patient when you start your patients on gonadotrophin treatment, and then titrate accordingly. So the counseling and continuous, compliance of the treatment is very important in that case. And secondly, I would like to thank Professor Saeed Maher for such a elaborative discussion when to refer your patient to endocrinologist, because many of our, although it's 24 months in UK and in European countries to refer to endocrine, but due to the social pressure in our country, usually after 6 months we are experiencing these patients in our clinics. Do not hesitate to do a complete clinical examination and a few underlying tests like testosterone, prolactin, LH, FSH, and underlying ultrasound and a clean thorough history. So this is what would lead you the way how to make a treatment plan for your patient. And thirdly, Professor Adrian Hill, a well-known name from Manchester. Sir, thank you very much for elaborating how to treat erectile dysfunction. It is a much more taboo in this part of the world where it is usually not discussed in detail, but testosterone deficiency usually leads to not only early osteoporosis but increased cardiovascular morbidity and mortality. It should be our a routine questionnaire from our patients to ask about these symptoms, because sometimes patient may feel shy to discuss these things. It should be our routine to ask these questions, because early testosterone replacement would not only improve the quality of life, but would also reduce cardiovascular morbidity and mortality for long term. Thank you very much.
Such an excellent presentations by our three elegant speakers, and I really appreciate Dr. Quinton's talk about the management of hypogonadotropic hypogonadism. The only key message for all of you is you should measure the testicular volume. If it's like more than 4 ml, then definitely, if it's less than 4 ml, definitely the combination therapy is much better than the HCG alone. So you should start combining FSH and LH to initiate in the spermatogenesis to treat the infertility in hypogonadotropic hypogonadism patient. And of course, this takes time to be like maturation of sperms and increase in testicular volume. So patience and counseling is very important. Second talk by Dr. Saeed Maher, and he nicely elaborated all the hormonal and causes for evaluation of female infertility. And as he said, much of these conditions are treatable, very treatable. And before going for an infertility center, an endocrinologist must help in those infertile females in evaluation and management. Lastly, Dr. Adrian rightly elaborated that erectile dysfunction in men is a cardiovascular risk factor. So you need to not only just treat the symptom, but also you address the cardiovascular risk factor related like lipids, blood pressure, diabetes. And then on the top of that, you need to evaluate the hypogonadism. And then you have a variety of the many options to treat the erectile dysfunction. And Dr. Adrian rightly told that it's a treatable condition and the patients can benefit from various therapies. Thank you so much.
Just one comment for Dr. Richards. So thank you for correcting me and enlightening me in treating the IHH in a new perspective, because I am seeing most of the patients with IHH, and I learned a lot from your lectures because I have been practicing in a different way. Or hopefully I'll implement your learning and I will definitely get along with this in future. Thanks a lot. Thank you.
Last comment is that, sir, I think the dose of HCG, LH is very important. So start with a low dose and then gradually increase just to make the peak testosterone in middle of the range. And because I believe the higher doses can also cause problem, and so best to start with a low dose and gradually titrate up. That's an important message. Thank you.
Thank you so much, our worthy chairs, for your valuable comments.